The webinar is now live.
Thank you very much. Hello and welcome. My name's Andrew Wilson. I'm the Chair of Cheshire CCG, and we're welcoming you to the July meeting of our governing body. I'd like to start off with a particular welcome to Dr. Rachel Hall, who's joining us for the first time as a governing body member, having been elected by the membership to serve on the governing body. So congratulations on the election and welcome to Rachel. I won't go through introducing other members. You can, members of the public are watching, their names are on the screens, and I'll ask the colleagues when you first speak if you would please introduce yourselves. This is a meeting which is held in public rather than a public meeting, so we won't be taking public questions as we go through, but there are public questions submitted beforehand, which we will attend to. We'll move now to item 1.2, which are declarations of interest, and I'll ask colleagues to declare anything that they have in terms of conflicts, which is particularly relevant to the agenda today, noting that everybody does have a written declaration of interest, which is available and live on our website. I'll also add that we are discussing the future of the structure of the system and the changes to the NHS, and I think we have to all recognise that we are conflicted in those changes, in that we know that the bill that Parliament considered yesterday would abolish the CCGs, and therefore we're all conflicted in that respect. So I'll pause to see if there's anything anybody wishes to declare. No, in which case we'll move on to our minutes. This is item 1.3 of your packs, is on page 3, and it's the minutes of the 17th of June. Is there anything on page 3, page 4, page 5, page 6, page 7, 8, 9, 10, 11 or 12? So I'm thinking nobody has anything to correct or add to the minutes and has nothing to comment or raise from them. No? Okay, thank you very much, and congratulations to Christine for accurate minutes. Can I just go back, because I didn't do apologies. So I think we do have apologies from Fiona McGregor-Smith and from Paula Wedd. Christine, do we have any other apologies? No, I'll take silence as a...
Matt Tyra.
Oh, and Matt, yes. So yes, I think Matt was hoping to join us, but has had to leave, not to be able to join us at the last minute. So thank you. We'll record Matt's apologies as well. Thank you. That takes us then to public questions. So do we have public questions? We do. So if you can, yeah, if you can move that on. So the question from Mr. Cairns on page 46. Well, you see that all the actions in the yellow section titled "Working with People and Communities" are put in place and properly co-production is done. Thank you. Is that the end of that question, Christine? Yeah, okay. And as always, we will provide a written response to Mr. Cairns on that question. Has anybody got any comments that they wish to make on that question now?
Andrew, I'm happy to.
Yeah, please, Matthew.
Yeah, so I suppose everyone probably referred to what that page on the table is, and it outlines really the duty of the integrated care system to ensure that there is the public voice in its involvement and its decision making going forward. I think the answer is this is for the place to do. So it's not just the CCG, as we've articulated in the past, it's for all partners of place to work together to ensure that there are existing mechanisms and new mechanisms to get public patients, carers involved in shaping, designing and making decisions around local services are robust and in place. it's been really reinforced by both the white paper and the legislation that there is a need to get the patient voice involved at an early stage, co-produced throughout it. All these things that we as a CCG have articulated over the last year, and it needs to be one of the things that we actively work with our partners on to ensure what the new arrangements are in the future. The public voice is at the forefront and they are involved. But I suppose, as I say, the answer really is it's something that we've got to work with all our partners to ensure that's the case going forward. I'll leave it at that.
Lovely, thank you very much. And just to confirm, that will be a written response as well to Mr. Cairns for in addition. Thank you very much. Takes us to item 3.1, which is the chair's report, which is verbal on this occasion, and I will keep it brief. I've written down to once again welcome Rachel, because clearly we've just been through that election process. To note that there has been a Senate meeting of our membership since we last met. I wasn't at the Senate meeting. I understand it was a very successful meeting. I don't know whether those two things are connected, but they may be. But it was very ably chaired by Dr. Rees, so thank you for that, William. I wanted to mention the joint committee. So we do have, we previously agreed the terms of reference of the joint committee of the Cheshire CCGs, and the first meeting of that is next Tuesday. And it's starting off with an informal section, considering in a very rapidly changing world that perhaps even the terms of reference that we have only just agreed may need to be revisited and rethought through in terms of meeting the asks which are in transition between now and March, and how CCGs functions need to be aligned so that they can be taken forward form the basis of what is now the ICB, was previously called the NHS body. And so that first meeting is on Tuesday, that informal bit, and then there is some formal business on items, actually just one item, which is on the agreed work plan of the joint committee. But I think we will, I think without doubt, be coming back to the governing body to discuss the joint committee and its development further. The other item I wanted to mention was other things that I've particularly involved with, which is in just the eastern part of the patch at present, although we have discussed this place-based memberships, which is the formation of a GP confederation, which is bringing together of our present GP federations in the Cheshire East part of the patch and working alongside the LMC to form a sort of single voice for general practice as changes go forward, and then an ambition for that group to work with NHS staff, i.e. what are presently CCG will be ICS staff, to form a provider alliance, a GP provider alliance for that patch, so that the general practice can be fully involved in the new structures and can see appropriate development to meet the aims of the system in providing more person-centred, generalist and closer to home care. So I think that's an important thing to mention. I don't intend to mention anything more. I'm happy to take any questions on any of those items. Nope. Thank you very much. We will move then on to section 3.2, which is the Accountable Officers Report, Claire, and it's on page 13 of your pack.
Thanks, Andrew. Good morning. Excuse me. Good morning, everybody. Quite a short report this month, so I'll just whiz through it. So, usual report. It covers areas that are not covered elsewhere. It's just to sort of say thank you to all the staff engaged in the work and the agenda that I'm going to discuss. So, COVID-19 still with us, and obviously we've got the roadmap unlocking on Monday the 19th, but still real concerns locally and nationally with the Delta variant, and we've got one of our DPHs on the governing body, so he may want to say something in terms of all the pressures of that, but obviously we're continue to work in partnership to do our best to fight this variant. I think 2.3 is really important for the governing body in terms of assurance. So obviously the Prime Minister's announced that the government's to establish a full statutory inquiry into the COVID pandemic. We have for the last 12 plus months with our internal group and partnership group been working towards being audit and inquiry ready. So in terms of decision making, in terms of the governance, in terms of the risk log and all the things that you'd expect us to have, we have been making sure we are prepared for any such inquiry. So you can see the details there. We don't yet know the terms of reference of the national inquiry, but we will be ready. We have started the process to sort of start preparing, but I think everyone needs to be aware that you know, your WhatsApps, your emails, your texts could be called upon. So to make sure that you have everything in order personally and professionally, but we're making sure from an organisational perspective that we are ready for that. We are working, and Neil's leading this for us in terms of working with our providers in recovery and restoration. That work continues locally, but also across Cheshire and Merseyside and the North West. Good progress has been made on that, so happy to answer any questions on that, or Neil might want to come in. We continued our internal COVID group on a fortnightly basis, which is proving successful. 3.3, you can see we are moving forward on our long COVID agenda, and this is when patients still have symptoms 12 weeks after developing them. So we have a number of patients nationally. Sort of the view is it's about 1% of patients have long COVID who've had symptoms. I think probably locally we may think it's more than that. There is national money coming down. You can see at the first bullet point under 3.3. We don't yet know how much is coming to Cheshire and Merseyside, and then what Cheshire's share of that is. There's a Cheshire and Merseyside service in Liverpool, which you can see in the box. A number of our patients have been referred to, but I think the key priority for us is to develop local services, working with our existing respiratory teams and community services, and obviously primary care. But I think the important thing raised in this point is around sort of the psychological support. It isn't just a physical illness, it's a mental one as well. So we have to look at both the physical and mental well-being of the patients who are suffering from long COVID. The vaccination programme continues at a pace and brilliantly, so thank you to Tracy and her team for coordinating and leading this. You can see under 3.4 that the ambition is we should have about 88% of the eligible population, and the eligible population is 18 plus now. It's open to all adults, and you can see there that the nearly 18s are likely to be offered a vaccination over the summer. So we're not sure if that's nearly 18, 17 3/4 or 16, 17 sixth formers, and those going off to university, but we'll be ready for that, whatever the model is for that. 3.6, you can see that we're looking to much more flexible offer now. We have had previously, you know, sort of booked services, booked vaccinations through the national booking system, our mass vac centres and pharmacies, and obviously they offer through the primary care networks and our hospital hubs. But now we're having a more bespoke sort of flexible offer with roving models, pop-up, walk-ins, weekends, evenings, etc., which are proving really successful. And it is that taking the vaccine to the population seems to have worked really well. Obviously, you know, door knocking and loads of work going on. I think thank you to colleagues in local authorities, public health teams, etc., all the insight work that we're doing jointly on that. And I think it's about the targeted approach to the different age populations, which has been really important as we move forward. Still lots of work to do. The young cohort, the 18 to 29 and cohort 12, obviously that opened up quite recently, and we're performing really well against our peers. I think our figures are sort of low 60s now, so that's fantastic uptake and performance in the last 2 or 3 weeks. Obviously, we are beginning to plan for phase 3, which is the booster vaccination, and all the information coming out around that, whether it's a sort of booster and flu at the same time. So work is beginning on that. We're waiting for the national specification and guidance, and that should be coming out imminently for primary care networks and pharmacies to apply to do that. So I'm happy to take any questions on that. You can see under section 4, the Youth Justice Service inspection across the sub-region. That's ongoing at the moment, and we can bring further information about that and the output of that at a future meeting. This is obviously really important in terms of our young people who are on the cusp of being part of that system. So we want to do as much as we can to support and work and protect them. I said last time, I told you about our year-end assessment of NHS England that had gone well. So thank you to everyone who participated and prepared for that. We've now had our sort of follow-up letter. There aren't any reg ratings as we've had in previous years, because obviously the system has been quite different over the past 12 months. There's a really positive letter that we got from NHS England, which we have shared with governing body members, and we can put it on the website if it's not there already. So thank you to everyone involved, and obviously massive thanks to all the staff who are part of the CCG, and we can advocate and we can tell everybody about all the great work that you've done. We have the opportunity to do that on your behalf. As usual, the workforce metrics figures, obviously, sort of we share sort of the previous month and the last month. I think interesting to see, you can see the days lost to stress, anxiety and depression have gone up. They're now, if you look at the percentage, 37.1% of the 407 days lost. That's about 150 days lost to stress, anxiety and depression. We had a really good conversation about all of this at execs early this week, and got an update on the wellbeing offer that we are leading, and thank you, Christine, for your support and input into all of that work. It is a worrying position, and we are working, and the directors are looking at this with their senior teams to understand the reasons behind the levels of sickness. I think there are issues in terms of just resilience, workload and change. So I think there are a lot of real reasons under the sort of the heading of stress, anxiety, depression. But I think, you know, again, I have to take questions on this, because as we know, you know, staff are our most important asset. But I know the execs and their senior teams are working closely with HR and OD on this to look at how we can support our staff. Few decisions taken under Authority Executive in 7, so I won't read those out. You can see those for yourself. So that's it. Thank you, Andrew. Happy to take any questions.
Thank you very much. And we do have questions. So I think we start with Gwydion, please.
Thanks, Andy. Gwydion is Governing Body GP. Thank you, Claire. I just wondered if able, you could expand at all on the detail around section 3.7, which was, you know, the early guidance that we're waiting for with regards to the autumn booster for COVID, whether or not that may or may not be given in conjunction with the flu, and then, you know, the provisional plans for the offer to the population, you know, that mix that you sort of highlighted between PCN provision, pharmacy provision, roving provision. And then I understand it might be difficult to give detail, but if there are any sort of views, it might help. Thank you.
Yes, thanks, Gwydion. Can I maybe bring in Tracy and or Andy McAlvey on this one, please, because they'll have more detail. We're still waiting for formal guidance, but there are quite a lot of there's quite a lot of information out there which we have to share. Tracy, Andy.
Andy, did you want to go first? I could see your hand was up.
If you don't mind, yeah. So we've had some of the guidance coming out, Gwyd, overnight. So that's landed, and we've got details now of the enhanced service that's on offer. So yes, what we're trying to, what the decision, some of the big decisions that had to be made is, can this be a practice-based type of delivery? Because that's one of the most efficient ways of delivering the flu vaccination program. The COVID vaccination issue, though, complicates that, and they've had lots of deliberations about how to do this. So it is going to be a PCN delivery model. There is still decisions to be made about which particular vaccine, having had, you know, certain vaccines earlier on in the vaccination program, whether a booster needs to be a different type of vaccine or not, and there's still some deliberations about that. But it will be on a PCN delivery model, and that, you know, will be following the similar rules. It will be a different contract. There will be a different enhanced service, and we'll be asking practices to sign up to a different contract, a different enhanced service. So there's a lot of detail out there now. It's been circulated to practices as well. So I think practices need to actually look through that, and we're obviously going to be encouraging uptake. And also sharing some of this with pharmacy contractors too, because We do need the wealth and the breadth of the experience that we've got in Cheshire to actually deliver a complicated booster program, but also the flu vaccination program. So it's harnessing all the skills that we've got in Cheshire to engage in this, because we are anticipating a fairly difficult winter, and as fast as we possibly can, we need to get patients vaccinated appropriately for flu and for COVID.
If I can just follow that up, please, Chair. So Andy's right. Literally in the last hours or so, some further guidance has come out, and it's about then working with each of our PCNs to encourage them, ideally, to go forward and help us with that booster programme. So I think there's some work to take place. We've got a meeting later on today to look at what else we can do to support practices to ideally take up that offer that's been made. As Andy said, the model that we're being asked to look at is around local delivery through PCN sites and community pharmacy sites in the main, not necessarily mass vaccination sites. So that's the model that seems to be emerging from planning beyond Cheshire and from Cheshire Merseyside and from national guidance. What we want to make sure that we've got is the most local service that delivers flu and COVID booster programme together. So we will also be looking at what do we need. We've had some real success with the roving model. So I think it's about us looking at what we need as two places to make sure that we deliver to the local population. So what follows now is working with community pharmacies, PCNs, the provider, which is CWP of our roving model, and doing some further analysis on the initial work that's already been done to be clear on what our need is, and then trying to make sure that we've got as many providers as possible providing that service. But yes, certainly at the moment the view is to not have the mass vaccination model in the same way, and that's what we're now working with. So I think it'd be worth updating through Claire's report in the future as to where we get to with that, but it's just to let you know that we've already done an awful lot of modelling around that to be clear as to what capacity we will need to make sure that we've got enough local services to meet our needs, and very confident we can do that. We've had great success with the flu programme. I know it's been reported in previous reports, but we should be very, very pleased with the uptake on flu last year. We wanted that to continue, and same with COVID, albeit that they've been delivered in very different mechanisms. So the next stage is to learn from both of those and to keep pushing on and to keep that message really loud. So I'm glad we're discussing it now, so that anybody that is listening knows that we really want them to have their booster jab for COVID and their flu jab. Thank you.
Thank you very much for those answers. Can I move now to Ian, please?
Thank you, and it just very much leads on from that. I just wanted to say the support from the work that Tracy and Claire have been doing on the vaccination programme. We've had a few bumps in the roads that we've been working through together, but some of the uptake's been, you know, really, really good. And I suppose it's just to build on what Andy and Tracy's saying, is that rover model where we take it to people and remove all those barriers makes such an important difference. Can understand the changes in methodology around the mass vac centres when it's played its part, but I suppose my only and there's two things I want to share. One is just on that, is that I still have concerns about what we heard last time of how busy our PCNs were, and you know, the capacity that they had to, when everything else is being asked upon them, and to think that they might be able to do that. Let's really encourage them. What can we do to support them to take that up? Because I'm worried that we could get left behind a bit because PCNs are so busy. So I suppose that was just my concern. So let's not switch anything off until we do that, and I'm sure folks will be on that. The other one is the innovative approach that, you know, from our colleagues and from the CCG and practices and this and CWP on that rover model. Let's not lose the good stuff, because last year all the social care workers and council services really struggled with some of the flu uptake because they couldn't get access to it, or going into the care homes and what have you. So there is a bit of a risk on that one. So that's why I was saying the rover model and taking it to where we can together would be grand. And then just to move on from that, really, and the reason why I referenced that, at the outbreak boards for Cheshire West and Chester, this is we get regular updates on this from Claire, Gwyd and Leslie are really helpful in contributing to those system challenges. We put out a public statement yesterday given light of the roadmap changes. And some of those things are, let's not lose all the good stuff that we've done. You know, we continue to get vaccinated the second dose, continue to wear face coverings in crowded spaces, continue to get tested, continue to meet outdoors where you kind of work from home, and also to self-isolate as well. That goes along with it. It's not really new stuff, it's just important to take, and I think that we know that what's coming in the winter, so we put that out. We felt it was really important because a lot of businesses are looking for that support for the welfare of their staff and customers, if you like. And then also we put some safe guidance out to businesses as well to promote, keep those COVID secure, keep the good practices going. It definitely isn't over, so I just wanted to bring that attention to the governing body, and thank you for colleagues for the support and getting that out.
Thank you.
And can I just come back? No, sorry, Andrew, can I just come back on that? I suppose just to assure everybody, we won't get left behind. I think you can see from our figures in Cheshire and across both places that we are probably, not that it's competition, but of course it is, first and second in Cheshire and Merseyside, and you know, right up at the top of the Northwest in terms of our achievement for vaccines across all of the age cohorts. So I think it's the working in partnership, being creative, using every avenue we have, that we won't be left behind. And so I don't think, you know, I want to assure the governing body that we won't be, and we'll continue to build on the work we've done. I think it's important that we use the insight from the COVID vaccine programme to support flu and vice versa, because obviously this last year, I think we had the best performance ever for our flu campaign, and that was across, I think, bar one of the CCG in the Northwest. So again, we can learn lessons, you know, between the two. I think it is important that we look at how busy general practice is, and we know that. So I think before we, and I know you're not saying this, Tracy, but in terms of the mass vac centres, we just need to look at what's the right model for the population of Cheshire, and it might be at different times of day and weekends, etc. So let's not sort of take anything out before we're absolutely sure on the numbers and the modelling, and I know we won't, but you know, we've just got to wait for, obviously the guidance is out. I'm sure there'll be more guidance and then more guidance, so we work with it, but I think the confidence we have in our programme and our approach should give the governing body sufficient assurance that, you know, we'll manage this through over the next few months, because obviously there's the normal flu campaign and that's going to be extended again to over 50s. And we'll just see how it pans out in terms of, you know, being co-administered or not, but we'll just work through that. So thank you to everyone who's involved.
Thank you very much, and thank you very much, Reen, for those comments. I think it's important for us to perhaps amplify that this isn't over, and that continuation of all the sensible measures that have been controlling the virus need to be continued in terms of, as you've said, Ian. So thank you. Christine, you have a question.
Thank you. Chris Morris, I'm an independent governing body nurse. Thanks, Claire, for the workforce data. I just wanted to ask really for an update, to come to a future meeting around how we're supporting our workforce, particularly in light of, you know, national guideline changes, their return to work, organisational change. I know there's a lot of work going on with the wellbeing plan, but I think it would be helpful for the governing body to see a little bit more detail in regards to how that's shaping up and how staff are feeling.
Thank you. Yes, happy to bring something in more detail next time. We are, along with sort of the wellbeing plan, we are revising our organisational development offer as well through health skills. We've sent out a communication earlier this week to say that until further guidance arrives, that we're not recommending that staff come back into the offices on Monday. That we look at how we phase that probably from the week after. And there are some staff across the organisation who want to come back, but it is the very small minority. So we're sort of working across all the directorates and obviously with our Smarter Ways of Working group to manage that in a safe and practical way. But I think, Christine, happy to bring something back. We can share something probably offline before the next meeting for governing body members, just to give a bit more of an update on the wellbeing offer. I think we're all really conscious, both it's about coming back to work. It's, you know, changes around the white paper. I think it's ongoing change, as I've said before. This isn't just change around, you know, COVID or the white paper. There's a whole sort of list of things, and our staff have been going through change for 2 or 3 years now, obviously with the sort of pre-merger, then the merger. And we're really conscious of that, and obviously all the issues of working virtually and sort of being isolated at home. So lots of encouragement and lots of work going on, and thank you to Karen Shorrocks in particular, who's leading this work with yourself and with Dawn Scott from Health Skills. So I'm confident we've got a good offer. It's, you know, obviously we want staff to take up the offer as well. So we are doing that through our directorate structure. So, but happy to bring something back next time. Thanks, Christine.
Thank you.
Yes, thank you, Claire. Really, really important subject. I'm glad that the governing bodies now have insight of some of that stuff that we're aware of and can keep an eye on things. Thank you. Right, thank you. That's and no further questions on the accountable officer's report. So we're moving on.
Sorry, Andy, I did put in the chat. Sorry.
Sorry, Leslie. Oh, I did. Yes. Sorry, I missed that one.
Sorry. Leslie Appleton, governing body GP. My question is around, well, I suppose comment is around long COVID. I'm sure we're all aware of how high the rates are at the moment, and that obviously we know that fortunately the vaccine programme seems to be working and we're having less admissions to hospital, although I think they are creeping up now, and less impact on the serious side of sort of you know, impact of COVID. But my worry is obviously with more people affected that that we'll be having more problems with long COVID, and I think that sort of level of 1% may be much higher. I suppose my plea is that this offer is not short term, that the support for these people in the very name of long COVID, it's going to be a long time that these people are going to be struggling. And if it's anything like the sort of chronic viral fatigue, that impact is massive on sort of primary care and the community, and we often have very little option for these people to try and support them. So I suppose it's a plea that this doesn't stop, you know, after a year or two, that this is with us for a long time, and you know, we need to support these people who are suffering with long COVID. It has a massive impact on employment and all sorts of areas. So yeah, that was just my point. Thank you.
I think that's well made, Leslie. Thank you. And I think it'll end up being a chronic long-term condition, won't it? And we have to sort of treat it and fund it and resource it appropriately. I think the point I made in terms of the physical as well as mental as well as physical well-being are really important as well, because obviously this is a new condition, or a new definition anyway. So thank you for that. I think you're absolutely right. And we don't know how many people as well. You know, as I said, nationally it's viewed as 1%, but I think it'll be more than that. And we just need to understand the consequences on that, you know, as you said, wider society in terms of employment, education, etc. So thank you. We'll do that.
I think Sinead probably, if you introduce yourself, please, Sinead.
Quick. Thank you. Thanks, Leslie. Obviously completely agree with yourself and Claire about long COVID. We've got a team working on that in the CCG, and there is a programme was put in pretty quickly for sufferers of long COVID that involved our colleagues in Mersey as well, having a sort of programme across Cheshire and Mersey. As we've realised the nationally and locally the extent of the issues you've described, Leslie, then we've started to work on the programme because we recognise that it needs to be local, it needs to be multidisciplinary, and it needs to be sustainable. As you've just said, this issue isn't going to go away. And I've been talking to our team that are working on this, and we're actually going to be training up local clinicians to lead this programme, so probably a GP with a special interest, but it doesn't need to be, you know, there's other specialties and other community colleagues who might well be able to lead this work as well. So there's going to be money and resource to skill up local clinicians to lead this work, basically. And I absolutely take your point about this isn't, we don't need a short-term solution, we need a long-term one. So thanks.
Thank you very much. I'm glad to hear that we're considering the generalist input into that rather than just the specialist input, which is, I think, really helpful. And that was Dr. Sinead Clark, one of our joint medical directors. Thank you, Sinead.
Go on mute, Andrew. Andrew, you've gone mute.
Thank you very much. What did I say? Did you hear the bit where I said thank you to Sinead? Yes, you heard that bit. Yeah. Okay. So we're moving. I don't know how I went on to mute. So we're moving forward then, please, to section 4.1, which is the primary care committee terms of reference. Actually, on page 20 of your pack. And Pam, I think you're going to take us through this, please.
Thank you. I'm Pam Smith. I'm a lay member on the governing body and I chair the Primary Care Commissioning Committee. The ask of the governing body really is to agree changes to the committee terms of reference. The committee reviews its terms of reference as it goes along and definitely annually. And it's just bringing a proposal to update the governing body, which gives clarity regarding membership titles in the terms of reference and deputy chair arrangements. You can see the changes in the document in red and blue, and basically I'm just asking that as this has been agreed verbally by the Primary Care Commissioning Committee, virtually, sorry, I'm just asking now for governing body approval of the changes.
Thank you very much, Pam. Does anybody have any comments to make? In particular, does anybody have any concerns about the changes proposed to the terms of reference of the Primary Care Committee? Nobody seems to have any objections. Can we take that we are in agreement with those changes? Lots of nods. Thank you very much. Can we record then, please, that we are in agreement with those? So thank you very much for that. Pam, that takes us to item 4.2, which is Integrated Care System Design Framework, implications for CCG governance. So I'm going to start this off, and Claire will want to comment on it as well. So this is these are things that we've been discussing with the governing body for a few weeks now, in terms of the changes that clearly are happening with the Health and Care Bill having its second reading in the House of Commons yesterday, and so an expected legislative framework which is going forward with an expectation that CCGs will cease to exist in on the end of March of 2022, and alongside the guidance that we received in our planning guidance about how we should proceed over the coming months and have a transition into those new arrangements. One of the things that planning guidance asks of us is to have a plan to how we are going to operate only at the level of the ICS, which first of course is Cheshire and Merseyside, or if it's included in the plans of Cheshire and Merseyside, operate functions at place. Of course, as a CCG, we're in the unique position within the Cheshire and Mersey system in that we cover two places, having merged the 4 CCGs, and clearly therefore decision making at the level of Cheshire doesn't fit into that planning guidance either for Cheshire and Merseyside or for either of our 2 places. And so what we're bringing to you today is in consideration of how do we move forward with the place part of that discussion. In both of our places, there are conversations which are happening with partners about what will be the structure and governance and ways of working for our 2 places, which are compliant with the proposals for the new ways of working, and those conversations are ongoing. But what we're proposing is that we think forward to say, well, how do we best fit into those proposals, and having our decisions made at the Cheshire level clearly doesn't fit in to support either of the places with moving forward, nor does it fit in with what's required of us in our planning guidance, nor does it fit in with what we know is going to happen or we expect to happen at the end of March of next year. So what we are proposing is that there are a number of options which are laid out, but that in the paper that Matthew's put forward, but that we consider forming committees for Cheshire East and Cheshire West, which will act as the main decision-making bodies for commissioning for each of those 2 places as subcommittees of the governing body, with the governing body delegating responsibility to make those decisions to those committees. There are then further options that we could put forward in terms of how who sits on those committees, because there's some flexibility which is offered, which is not available to governing bodies, because the Act of 2012 does lay out who can and cannot sit on governing bodies, but it doesn't lay out who can and cannot sit on subcommittees of governing bodies, and therefore we have greater flexibility if we were wishing to widen the membership of those committees. And so what we have to you today is your considerations of the paper and your views of the way forward, and your approval of the suggested way forward, which is the formation of place-based committees. The paper then goes on to talk about other options which might be more compatible with the future, in particular joint committees. Now, clearly, it is not in our gift to make a decision that joint committees will be formed. That's a matter of discussions with partners. But we can make the decision that we would be willing partners and would be seeking that sort of arrangement, which is going to step further forward than us having just a CCG place-based committee, although you could argue that a CCG place-based committee would be a step towards that. So I think what we're after from today is those thoughts and considerations and your advice on an agreement with those various options. I don't think we can necessarily say this is it and this is what the future will be, because it is subject, some of it will be subject to further discussion with partners. We can make the decision that we believe that we need to be operating at a place level and not at a Cheshire level, and therefore that we wish to move forward with those place-based committees. I'm going to shut up and pass over to Claire for anything to add on to that, and then we'll open the discussion up to Claire. Do you want to add anything?
Yeah, thank you, Andrew. I think it's just important to even just go back to the first page of the paper, on which the paper outlines what the guidance says, and it's really helpful. But I think 1.3, in terms of the dual governance at a Cheshire and Merseyside level, the language now has changed. Now the bill's been published, the white paper's been published, and the bill went through Parliament yesterday. In terms of it's now an integrated care board, an integrated care partnership at a Cheshire and Mersey level. As you know, all of the functions of the CCG will disappear, and all of the functions and responsibilities will transfer into the ICS. So whatever happens at place will remain at the accountability of the ICS, so it'll be ICS in place. So NHS commissioning will be through the ICS, but in place. So whatever we do now is preparing us for a future governance state of sort of ICS joint committee with a local authority, if that's the option. So I think it's a really helpful paper, and you can see the timescales and the timelines of what we've got to do by the end of Q2, Q3, etc. And if you go to 4.3, that sets out the options for place-based governance, sort of the national options. And so it gives a whole range of different sort of committee structures. And I think the ICS is expecting a multitude of these across Cheshire and Merseyside, and it has been clear that it doesn't have to, they don't all have to be the same, and I think that's important in terms of the permissions for local places and where we are in our sort of relationships and how we want to move things forward. But I think the key thing today is this is about a sort of a step towards the 1st of April, and the 1st of April is not sort of the final deadline. That's just another step on a long journey of joint working between the NHS and local governments and wider partners. So I think what we just want to do today is make a decision or a recommendation that myself, Andrew, and others can go to our local partners with in terms of is the ambition for a joint committee, or are we happy to stay with a single place committee? And I think it's about that journey and that stepping stone. So I think the recommendation is that we move as quickly as possible to a place committee, which will be sort of splitting the CCG governance and working with our partners, and as it outlines in table A, that we would invite other partners into onto the governing body in place-based committee to work with us on and make decisions with us. But I think our ambition would be to move to a full joint committee on behalf of the ICS from April 2022. But obviously this isn't just the CCG NHS governance that would need to change. Our partners, particularly local authorities, governance and committee structures, would need to change to accommodate that. So that's part of the conversation that we would have with partners. But I think it's about what you recommend and support today to enable myself, Andrew, and others to take those discussions to our partners. Thank you.
Thank you. I think in our considerations about this, I think what we have to have in the front of our minds is how do we best serve the population. It's very easy to get wrapped up, isn't it, in the governance and the technicalities of this, but how do we best ensure that everything continues as smoothly as possible between what we are doing to what the ICS will be doing, and that is as productive as possible. I think that's the most important consideration for us all. Before I open it up, I'm just going to make the point that in the recommendation, there's a slight confusion, and it recommends that we'll be selecting option 2, whereas in fact I think that actually the suggestion is that it's arrangement 1 in table A is what it's referring to when it talks about the CCG Place Committee. Of course, governing body's ambition may be different from that, but I think that's what that's referring to. Is that right, Matthew? Yes, lovely, thank you. Right, opinions, comments, discussions, please, colleagues. Do my best GP use of silence, and still nobody is speaking up. So Peter, please.
Thanks very much, Chair. I'm Peter Monday, one of the lay members for governance. I think it probably is appropriate for the members for somebody from the Governance and Audit Committee to make a comment. From a governance and audit point of view, I've got great confidence in the approach that's been suggested. I can't speak for my colleagues because this hasn't been through the committee, but I think it is worth me just putting that personal view forward that I'm fully in agreement with this.
Thank you very much, Peter. Leslie, would you like to comment?
Yeah, so I'm in agreement like Peter that we move forwards with this. I suppose making sure that we don't get bogged down in the governance, like Andy says, that we have patients in the community at the heart of the decisions that we're making, to make sure that we carry on the good work that Cheshire CCG has been doing, and that we continue those relationships across the whole patch, even though that these will be 2 different place-based committees, and I'm sure that will continue. And I think just making sure that I suppose that services don't suffer while we're working towards this, and that we keep that good work going. So that would be my plea, but I'm in agreement with this.
Thank you very much. And when colleagues speak, can I just, because there's a slight confusion on the paper, which Matthew's helpfully clarified in our internal chat, but can I ask colleagues to comment on which parts of the potential proposals that they are supporting? So we might be saying, oh, well, actually we do support the eventual move towards a joint committee, but clearly that's a matter of negotiation. But we would anyway support a movement towards a place-based committee, and whether you would or would not say actually the members of that committee should be wider than just CCG, and we could make the offer to partners to make that wider than just CCG, perhaps including certainly local authority colleagues and potentially provider colleagues, which is clearly in the new ways of working, that's the direction of travel. So if we can get a feel of where people are with those options and how you want us to put those forward, that would be helpful. So Tracy, please.
Thank you. Yeah, just to say thank you. There's an awful lot in this paper. It's very complicated, and I think just thanks to Matthew and others who've worked really hard to try and make it clear for us. I think Leslie's probably said what I want to say. I don't think any of us want to spend an awful lot of time talking about governance. We want to spend I think we want to talk about how can we do the right things for our population and the population's health. So it's finding the mechanism which we have enabling governance that allows us to do that. So I support the recommendation in the paper, and I'm of the view that we need to get on with that so that we can progress with a new structure as quickly as possible. So I do think it's about bringing partners around the table, and I think, you know, as fast as possible to get on with that. So I support the recommendation that's in the paper on that basis.
Thank you very much. And I can see in chat, I'm going to, and people are put things in chat, but other people are agreeing, so I'm going to articulate what that says in that chat. And probably add a little bit to it just to see whether this is where we are and what we have agreement on. So I think colleagues are saying, yes, please move towards two place-based committees of the CCG. But the ambition actually would be to move towards a joint committee if that is what colleagues, in particular local authority colleagues, wish to do. And that informing that place-based committee, I believe people are open to the membership of that being wider than CCG colleagues, to include wider system partners, local authority and provider colleagues at least. Is that a fair summary of where colleagues are? I'm getting lots of nods and nobody's putting their hands up to object. Okay, and we've got more agreement in the chat. Okay, so I think we can potentially, any further comments on that, particularly any thoughts about problems, pitfalls, concerns in particular? I'm going to pause and see whether anybody has. Dr. McKelvey.
Just that we're a membership organisation, Andy, and I just think, as well as the governing body being able to progress this, which I think is the right, we do need some pace on it. We do need to concentrate on improving care. We need to improve, you know, working with our partners. But as a membership organisation, I think perhaps we do need to give some reference to our members and ensure we've got their approval as well moving forward.
Thank you. That's a really important point. I think actually what we probably should do is write to the membership to inform them. And I think our next membership meetings are not until September, possibly October. So yeah, absolutely. So I think we'll write out and we'll let membership know where we are. But Matthew, this will require constitutional changes?
Good question. In theory, yes, and that's what we'd need to work through. But where we are currently in the run up to the establishment of the ICS, getting sign-off from NHS England formally might not be needed as long as we've demonstrated engagement, got their approval as well. But that's part of what we need to work through with partners, not just you know, ourselves. But it is a substantial change, and Andy's right. You know, we do need to engage and get approval and agreement on the membership.
Andrew, if I could just come in, I mean, absolutely agree in terms of the membership, but I know NHS England are trying to be as sort of pragmatic and sensible as possible in terms of this, because otherwise there'd be, in terms of stepping stones for future governance, the whole year would be taken up with approving or not constitutional changes across the CCGs nationally, as we make, you know, little changes here, there and everywhere. And obviously we know with the advent of the joint committee of the CCGs, that would be 9 CCGs doing something similar across Cheshire and Merseyside. So I think it's maybe how we work pragmatically with our peers in Cheshire and Merseyside up to NHS North West, have that conversation, try and maybe have that conversation once on behalf of all the CCGs.
Look, thank you. And I think it is very worth noting, we have discussed this with membership already to some degree. We have had a discussion about the fact they may wish to operate at place level, and there was wide agreement from membership on that. They didn't formally put it to them. If there are constitutional changes which are substantial, then we do need to go to membership, because that's in order to that change, we will need membership approval. Thank you very much. So I don't think anybody is raising any other issues. So I think if my summary can stand, please, Christine, as what we have agreed to. If you've got that, if not, I'll say it again. I'll pause. If you say, please say it again, I'll say it again. If you don't, I won't. You haven't? Brilliant. Thank you very much. So I think we can take that as agreement. We'll supersede the recommendation of actually what we've considered with that summary, please, because I think it's moved on a little bit as we've discussed it. Thank you very much, colleagues. That takes us to item 4.3, page 49 of your pack, which is the finance report. Over to you, please, Linda.
Thank you, Chair. So I'd just like to apologise. Sorry?
Introduce yourself.
Oh, sorry. My name's Linda Risk. I'm the Chief Finance Officer for NHS Cheshire CCG.
Thank you.
Thank you. So thank you, Chair. Can I just initially apologise for the lack of titles on the table on page 53. I know you've all been sent this morning a new version of the presentation or the paper with it on, so hopefully that can then be amended on the website. So this is the first report of the financial position of the CCG this year, and it covers the position year to date to the end of May 2021 and the outturn for the 6 months.
You've gone on mute, Linda. Linda, you've gone on mute.
As you'll all be aware, we're only really working at the moment for the first 6 months of the year, known as H1. And so there will be a further planning round for the second half of the year for H2, which is the period of 6 months to the end of March 2022. So the year-to-date deficit at the end of May 2021 was a 7.4 million deficit, but within that we're awaiting for funding for the costs included in the deficit which support the vaccination and the hospital discharge programmes. After receipt of that funding, the year-to-date deficit is 4.1 million as at the end of May. So just for clarity, the CCG is incurring costs in relation to vaccines and HDP, and then we have funded these costs in arrears. They're referred to as out of envelope costs with our allocation known as the envelope, which I think is quite confusing, but just to sort of say that. As at the end of May, we are predicting a break-even position for the first 6 months of the year to the end of September. You will see within this break-even position, we have a requirement for a £12 million QIP. QIP, Quality, Innovation, Prevention and Productivity, which is basically efficiency savings. We have set up a financial recovery group, which is going to work within the CCG, but also across the whole system, including our providers and the ICS, to identify QIP to sort of recover the position to break even. So this is the position as at the end of May, and the performance at a glance reflects that position and reflects the budget and the plan that was agreed with the ICS as at the 6th of May. Since the 6th of May, we have had a couple of further planning changes. So the ICS required the CCG to make a 1.9% efficiency saving, QIP, against their non-NHS expenditure. So that's what they asked us to do. That's our target as a CCG, and that was the minimum. And all of the other CCGs and the providers in the whole system have been asked to make efficiency savings so that the system can get to a break-even position. In addition, the CCG reviewed its costs, and we identified that we would get additional funding for CHC, some of the CHC costs around from the hospital discharge programme. So effectively, this reduces the costs within the envelope by about £2 million. So the result of the 1.9% efficiency was that we got another £5 million from the ICS to support our position. So in the reporting for the end of June, you will see that our QIP ask has reduced by £2 million worth of additional funding from the HDP, and £5 million additional funding from the ICS, which has reduced our QIP from £12 million at the end of May to £5 million at the end of June. So it's still a significant ask, basically on a small number of budgets, but it is a much improved position. So the performance at a glance does not reflect those additional changes which happened in June after the financial tables were produced. So just to say the key risks that we're sort of facing going forwards, which have been identified by the Finance Committee as the key risks to note to the governing body, was the increased recurrent cost of the health system due to COVID-19, and I do think we're seeing that. The ability of the CCG to meet its statutory break-even position, particularly around the increased costs of CHC and prescribing, above the levels of growth that we've included in the budget. And the financial governance and control as we move the financial control of the position as we go through transition to the ICS. Thank you. Any questions?
Are there any questions?
Silence. Was that?
In which case, I'll ask Linda. Could you just outline? You said that we got a £5 million QIP cost saving programme against a relatively small number of non-NHS. Is that right? Budgets. Could you just outline what sort of budgets are those? So
it's the things like the non-NHS budgets are sort of our IS contracts, for instance. Would be the prescribing budget, the CHC budget. So it's things that are not basically NHS providers, because the NHS providers already have an efficiency saving against their budgets, because they have to make an efficiency saving themselves.
Thank you. Any further questions for Linda on the finance? Claire.
Yeah. Thank you. I think it's quite detailed, that, Linda, in terms of what's been presented in the on the paper and then the additional information. So I think just it's quite hard to understand, and I think just in terms of income, expenditure, savings, etc. I just think we just need to ponder on that. I just want to ask you in terms of the running cost surplus. Can you just describe how we've made, well, there's a target to have obviously a surplus, and how we're achieving that?
So the running cost surplus, I think that's incorrect. I think what's been put into that table is actually the budget. The actual, if you look at the summary on a glance on the new one you've had, if you pick that up, you will see that the year-to-date position is actually an underspend of 58,000, I think, with a break even. So what's been put into the performance at a glance at the summary with the key financial indicators is actually the budget. So the target is, that's right, the target is 2.3 and the actual is 2.2. So we're going to make a small surplus at the moment of approximately £58,000. So yeah, no, they're the right figures. So the target is 2.3 million and the actual is 2.267 million. So we're just making a small surplus, and we're planning to break even and planning to spend the whole budget.
Okay.
Thank you. I will bring in Tracy and then Pam, but I'm just going to make the comment that Dr. Rees has put in, which is we mentioned IS, which is independent sector, which is essentially private hospital spend, and CHC, which is continuing healthcare, which is the money that we spend supporting healthcare needs for those that have a continuing problem. Often that's nursing care, either in a nursing home or in their own home, isn't it? So can I bring in Tracy, please?
Yeah, thank you. I should have introduced myself earlier. Apologies. I'm Tracy Curl, Director of Strategy and Partnerships. Linda, you've probably said this, so if I haven't picked it up, I do apologise, but I don't think I fully understand on page 50, and I know it's detailed further on, the difference between, we've got the year-to-date deficit of 7.4 million, that bit makes sense, but then we've got the 10.2 million below, and I don't understand the two, how they all relate. Can you just help me a bit more with that?
So the 10.2 million is, so one is year to date and the other is forecast outturn. So if you look on the H1 forecast, what we're saying is we will have a deficit of 10.2 million, but that is going to be funded by the out of envelope funding. So it will be funded by vaccinations and also the hospital discharge programme. So whilst it looks as though we're going to have a deficit of 10.2, we will also receive an additional 10.2 million pounds worth of allocation. So we will come to a break even at the end of H1. So the 7.4 million is our current position, where we've got a deficit of 7.4, but we only predict year to date that we are going to get a additional funding of 3.2 million, because we have a deficit in some of the areas, and the biggest area we have a deficit in is CHC. And we know that that is the case because the local inflation and growth around CHC was higher than the predicted by national figures, and the ICS asked us to put in the national growth. So we will see a growth of CHC above the budget. So the year-to-date budget is higher, but we're still predicting that we will get to a break-even position. Does that make sense?
Yeah, the minute you said forecast outturn, I then understood what you meant. So I suppose in the table on page 52, I guess it uses different words. So this is for the non-finance people, me, I guess. I'm just better with the same terminology because then I can follow what we're saying. So apologies, I do get it now, but there may be others that would find it useful just to keep the same terminology and format for the non-finance brain of me. But thank you, I now understand.
Yes, okay.
Thank you very much. And another bit of a abbreviation buster, H1, the new NHS term for the first half of the financial year.
Yeah, H1 is the first half of the financial year, and we've got H1, H2.
Okay, Pam, you have a comment to make?
Okay, apologies because I too am not a finance person, but thank you, Linda. I understood that far better than I understood the papers. But am I correct then that at year end we're going to have to have found £5 million worth of savings, or is that at the end of the 6 months?
At the end of the 6 months.
Okay, so could that be doubled by the end of the financial year?
Yes, but we don't know yet. We don't know what the allocation will be for H2, the expenditure, or we have no idea.
And I know you set up a group to look at how we're going to achieve this, but how confident are you that we're going to achieve this, given that we've got all these other things going on in the system in terms of the changes that's happening in the CCG, the place-based things that are going on? How confident are you that we'll actually make those efficiencies?
I have concerns that we will not be able to make the break-even position. I would say that, particularly in light of the fact that the CHC and the prescribing growth that we've included was far below what we would have included if we'd if we hadn't used the national ones, because I think our local growth is higher. So particularly around those issues, we're obviously looking at all of the other things that we can do. So there will be a paper is going to execs on, I think, the 23rd of July around what we're looking at and the areas we're looking at to try and find some non-recurrent means of covering the 5 million. So I think there is a significant risk that we won't reach break even.
Thank you. Any further comments on that? And I'm assuming we will continue to see updates depending on how often we meet going forward on this and on that challenge, and that challenge is one shared with with partners across the system.
Yeah.
Because I think as we increasingly discover, there are rarely solutions in one part of the system.
Yeah, so we're already talking to our local providers and also to the ICS, because the ICS has a collaboration at scale programme as well, which is hopefully producing some efficiency savings. So hopefully together as a system of Cheshire and Mersey, we will be able to reach a break-even position overall, which is now the requirement, is that Cheshire and Mersey as a whole, including CCGs and providers, all get to a break-even position together.
Thank you. Claire, did you want to come in?
Yeah, that was going to be my point actually, because if you remember when we were asked by the ICS to achieve break-even, we sent a letter back saying we would work towards that, but as part of a system, and we listed, I think, 6 areas where we committed to working as a system, but believe that they would be absolutely instrumental in any savings. So are all CCGs in Cheshire and Merseyside in the same position, different levels of risk around savings, but ability to achieve those is only through system working, and that's system at Cheshire and Merseyside as much as it is locally, Linda?
Yeah, so we're all meeting together on a regular basis. Next week, we've got a meeting of all of the providers and the CCG directors of finance to go through the end of the H1 position, the position for the first 6 months of the year, to discuss how we're going to get to break even and what challenges there are and what opportunities. So we'll be doing that not tomorrow, but next Friday. So there is definitely a push to do this on a across Cheshire and Mersey footprint, using a more system approach. And also in terms of the levels of efficiency, the minimum was 1.9%, which is what we had in Cheshire CCG. Some of the other CCGs have a higher efficiency ask.
Thank you. Suzanne, you wanted to come in?
Thank you. Suzanne Horrell, I'm a lay member for governance. I think it's important we highlight we're in quite strange times at the moment. As chair of the finance committee, it's quite a source of frustration, and I'm sure Linda and her team feel it as well, in that we're getting constant changes to our allocations, our funding, what's in envelope, what's outside envelope, which makes any sort of financial planning, quip saving, etc., quite difficult to do. So we've suddenly got a 5 million quip saving to find, and we're in July already. We've got till the end of September in theory to find it. I think these aren't normal times. This isn't the normal way we would run the finances, and so I think there needs to be a bit of understanding that it's quite fluid at the moment. Is probably the best way to put it. And with that, then it becomes limited when you're on block contracts with the acutes. Your ability to find efficiency savings is reduced quite significantly. And I think at the last governing body, we already identified the situation with CHC and the lower growth built into our budget than we would normally expect. The fact that prescribing is focused on quality rather than efficiency savings this year. So, and they're the 2 key areas that we would normally look to for efficiency savings as a CCG. I think the fact that we've now picked up on the fact that this is a system-wide risk, this is something we're trying to address as a system and not just as a CCG, is important. But then we know that all the other providers have also got their own efficiency savings. So I think it's important to put that into context as well. So I think, yes, there is a big risk that we won't achieve the efficiency and we won't achieve the financial standard at this stage, but that has been recognised. Thank you.
Thank you very much. Are there any final comments on the finance paper before we move forward? I don't think there are, in which case I think we're asked to note that position. And thank you to Linda for that presentation. And we'll move on now to the section 5.1, which is the report of the committee chairs, is on page 55 of your pack. And we're asked to note that the items the committee wish to bring to our attention, and and note the items which are listed in section 4. So that's sections 3 and 4 of the report. We have, I think, 3 committees which have contributed to this, which is finance, quality safeguarding and performance, and strategic commissioning. So I'll go to each of those chairs if they have any comments to make about their report or anything they particularly wish to highlight, and then I'll go to the wider governing body for their comments or questions. So Suzanne, can I ask you first if there's anything you wish to particularly highlight from this?
Thanks, Chair. There's nothing specific. I think it's quite self-explanatory, but happy to take any questions.
Thank you. Christine?
Thank you, Chair. The committee continues to look at the potential for harm caused that potentially is caused to individuals as a result of long waits from COVID pandemic and changes in service, and we continue to seek assurance around communication processes to those individuals so that they know what's happening with their treatment. So those are key points. From a performance perspective, I think Neil was just going to give you a brief headline. Neil?
Thanks, Christine. Yeah, we as we have been doing for recent meetings, have been reviewing the recovery programs, and it's been really pleasing to note we have been seeing significant reductions in the numbers and length of waiting times, recognising that the starting point was a really challenged position. I guess the thing that we focused on this time was the potential risk to that recovery program coming from the incredible pressure that services are under, not necessarily directly linked to the Delta variant and increased prevalence of COVID, although that's clearly not helping, but just in terms of the levels of contacts and need that we're seeing across sectors, whether that's primary care, mental health or secondary care, including the heightened acuity of patients' needs. And just as an example, we talked about some information from North West Ambulance Service where they've seen an increase in overall contacts, but as a proportion, they are seeing a much greater increase of what we would call category 1 calls, which are the most serious type of calls they receive in terms of clinical acuity. And that's probably representative of what the wider system's seeing. So as I say, we're seeing good progress, but we're seeing a real challenge. The Delta variant is presenting an additional challenge in terms of workforce, and that we've got both staff absence from COVID infection, but also from isolation, which is increasingly placing pressure on services again across the whole system. So good progress, but increasing challenges we're seeing as we've gone through the past few months.
Thanks very much. And then if you can go forward to Wendy.
Yes, Wendy Williams, lay member. We have been doing in the strategic commissioning deep dives. So on behalf of the governing body, following on from what Neil has said, we have looked at the recovery in depth, which is very helpful to be able to spend that time and go through finding out exactly what's happening and the hard work that's going on. This last time we've been looking at we had a programme management update. Obviously the programmes that are underway within the CCG are extensive, and given the changes that are afoot now that we've just been discussing in previous items, the programme management is prioritising, focusing and channeling down a great many of these to ensure that their delivery is assured. So that was a really reassuring update that we had at the last SCC. But other than that, no, nothing else to report.
Thank you very much for all of that. If I can open it to the wider governing body for any questions or comments. No, I'm not seeing anything, in which case I will thank the committees and the chairs for the report, which I always find helpful and useful to be able to go through. So thank you for that and for the work you continue to do. And we'll move on to section 6.1, which is on page 65 of your pack, which is the forward planner. Simply for noting. So I'll pause to see if there's any comments on the forward planner, which is probably going to be quite a fluid thing in the world that we're presently in. No, no further comments on that, in which case it will just leave me to thank you for your attentions and contributions to today's meeting, and to close the meeting, and to remind you that there is a short informal meeting following this if you go to the Teams link. Thank you very much.
Thanks, Andrew.